glaucoma is not only a common eye disease.
It's actually much more than people think. It's one of the leading causes of irreversible blindness worldwide.
And while it can be a disease that
Creeps up over the years, and unfortunately, it can go unnoticed until vision is already affected. It got damaged little by little. The patient doesn't realize that they have it.
it's also becoming increasingly treatable.
Lately, because of technologies, you diagnose earlier, you treat earlier, and you reduce the chance of meaningful vision loss.
Discover glaucoma, setting sights on improving outcomes. Inside this edition of CTSI Discovery Radio. Welcome to CTSI Discovery Radio. I'm your host, Brian Belmer. CTSI Discovery Radio is brought to you by the Clinical and Translational Science Institute of Southeast Wisconsin. The CTSI is a consortium of researchers, doctors, scientists, and others representing 8 institutions, including the Medical College of Wisconsin, Milwaukee School of Engineering, Marquette University, the University of Wisconsin-Milwaukee, Children's Wisconsin, Froedtert Hospital, Versity Blood Center of Wisconsin, and the Zablocki VA Medical Center. The CTSI works collaboratively across all of our member institutions. Our mission is advancing health through research and discovery. Glaucoma is an eye disease that can gradually deteriorate our eyesight up to and including a complete loss of vision. But while its outcome can be quite severe, it doesn't have to be. Today, we think it's important to learn about glaucoma, what it is, how to battle it, and what the latest therapies are to treat it. To answer these questions and more, we invited a couple of experts to bring us up to speed, beginning with Dr. Sylvia Lara Moses, Assistant Professor, Department of Ophthalmology and Visual Sciences, and an expert in surgery, laser surgery, and management of glaucoma and related eye diseases in the Eye Institute at Froedtert and the Medical College of Wisconsin. Dr. Lara Moses begins by telling us that
Glaucoma is a chronic eye condition that damages the optic nerve, the nerve that connects your eye to your brain and allows to see.
as far as how many people's optic nerves are impacted by glaucoma,
It's actually much more than people think. It's one of the leading causes of irreversible blindness worldwide. More than 80 million people are living with it right now.
and the reality is, unfortunately,
That number is growing as our population gets older.
so what can be done to reduce this increase across our population? Dr. Lara Moses says, first, we must consider the risk factors of glaucoma, and there are several.
Anyone can get glaucoma, but there are certain risk factors.
For example, age.
Age is a big one. Usually it increases over 40 years. People over 40 should start having regular exams, but it's more common after 60 years old.
Still, as Dr. Lara Moses tells us, anyone of any age can get glaucoma. This includes children.
You know, we see glaucoma in young children. Sometimes the problem is that the parents doesn't realize that. They just see that the baby has very nice eyes. They think that is cute. The problem is that they arrive with very advanced congenital glaucoma, and sometimes we cannot do so much for these babies. Fortunately, it's not very common.
In addition to age, other contributing factors include genetics,
Family history also matters. If someone in your family has glaucoma, your risk goes up.
race, or ethnicity.
We know that people of African, Hispanic, or Asian descendant patients are at high risk to develop glaucoma.
comorbidities with other diseases or conditions.
Diabetes, high blood pressure, or even high myopia can also play a role. Even conditions that affect your immune system, metabolic conditions, patients that used to use medications that raise the ocular pressure, or patients that have sometimes low pressure can develop low pressure glaucoma.
What about gender? Are men and women at equal risk of developing glaucoma?
Men and women have the risk. Or some studies mention that women has a little more risk to get glaucoma.
Why is that?
We don't know, but could be changes in the metabolic, in the hormones, or simple because women sometimes they go more frequently to the clinic to check the eyes. But the difference is minimal, it's not so much difference.
As Dr. Lara Moses explained, glaucoma negatively impacts our eye's optic nerve. But what exactly is the optic nerve?
The optic nerve is small bundles of fibers, and the retina, all the fibers from the retina, they go together, they travel from the eye to the brain, and is what connects and take all the information, the visual information, and transform in the brain vision.
Then the question is, what causes glaucoma to occur, negatively affecting the optic nerve and impacting a patient's vision?
Inside the eye, we're constantly producing a clear fluid called aqueous humor.
Aqueous humor. What's that?
Aqueous humor is a fluid that have all the nutrients inside the eye. It's like the tears, but it's inside the eye. It has a circulation inside the eye, and it's a specific go to the posterior part of the eye. It goes through the pupil to the anterior part of the eye, between the color of the eye and the cornea, that is the length in the very front part of the eye, the clear part. And in this area, this fluid go through small channels, and they go outside through the circulation. It's a natural fluid that nurses all the structures inside the eye.
This essential fluid keeps proper ocular pressure and drains from the eye through what's known as the drainage angle.
The drainage is like a small grill of fibers. There are a very precise connection that allows to get the fluids out of the eye, and the fluid pass through these connections and then to the circulation. This is the way that it goes outside the eye.
However, when someone has glaucoma,
the problem starts when the fluid doesn't drain out properly. When drainage slows down or get partially blocked, the fluid builds up and the pressure inside the eye rises, kind of like a sink with a slow drain. And over time, that higher pressure can push up the optic nerve and cause damage.
That pressure is known as intraocular pressure, or IOP. Dr. Lara Moses explains.
This is what I tell my patient. When you lose this balance of production, it makes the changes in the consistence of the eye. It's like the tires of the car. When you have more air inside, then you say that tire has very high pressure. In the eye is mostly the same.
So when the aqueous fluid doesn't drain properly and the intraocular pressure in the eye increases,
if normally the pressure of the eyes is around 10 to 21 millimeters of mercury, over these numbers is when the optic nerve can get damaged.
But here, she stresses that
the important part is that glaucoma isn't only about pressure. Some people can have, that I said before, normal eye pressure, but the optic nerve is more sensitive, or the blood flow is weaker, especially at night. Some people develop very low pressure before go to sleep and damage the circulation of the nerve. In those cases, the goal is still the same: lower the pressure even further and improve circulation to protect the nerve.
That said, she explains there are two different main types of glaucoma. First, there's open-angle glaucoma, which is
the most common one. Imagine that the angle, when it is open but is not building the fluid outside, it's not draining properly, we call open-angle glaucoma.
As far as what causes open-angle glaucoma,
the cause is uncertain. Even with all the technology, we don't know exactly what is this block. It looks normal, it looks open, but it's not functional very well.
leading open-angle glaucoma to be characterized as a slow, silent disease because it's
the one that creeps up over the years without causing any pain or redness. And unfortunately, it can go unnoticed until vision is already affected. It progresses usually very slowly. It got damaged little by little. The patient doesn't realize that they have it.
But eventually, over time, symptoms begin to surface when the patient will
usually lose the vision from the side, from the periphery. The patient starts with a small spot of blindness. Then very advanced, where the patient lost most of the peripheral vision, is when they realize they have the condition. Then they go to the doctor for a checking.
The second main type is called angle closure glaucoma.
Here, the iris, the color part of the eye, blocks the drainage system, and the patient feels severe eye pain. They have headaches, see even halos around the lights, and this is an emergency and it's immediate treatment because in this kind of glaucoma, the pressure builds up very high and it's really painful.
Making it very different from the slowly progressing, silent variety of the condition.
Yes, it's something that you need to manage. It's an emergency. This kind of patient needs treatment right away to decrease the pressure, and most of these patients finish on surgery.
Next, Dr. Lara Moses shares her expert insights on how glaucoma is diagnosed.
We diagnose glaucoma with a complete eye exam. We check the vision. We check the pressure with specific devices. We check all the areas of the eye, check if the angle is closed, is open, or if it has some changes that made us think that they can have malfunction. We dilate the pupil to check of the retina, check the optic nerve. Finally, we perform the visual field. This is a test that tells us if part of the field is depressed.
Once glaucoma is detected, how is it treated?
The main goal of the treatment is to protect the optic nerve by lowering the eye pressure. We can do that in three main ways. With medication, we can use laser therapy or surgery.
The most common treatment for glaucoma are medications, specifically eye drops.
Most of the patients start with eye drops. We have different kind of eye drops. Some reduce how much fluid is made in the eye. Another help to drain more efficiently. Each person has personalized treatment. Some people think that the small drops cannot have any effect in the body, but they work very well when they used correctly.
As mentioned, there are also laser therapies and minimally invasive surgical options.
Each of these options is carefully selected for the type of the glaucoma, the severity, age of the patient. We need to check what is the best treatment for them.
Although it's a manageable disease, it's equally important to manage a patient's expectations about their treatment.
It's treatable. We can decrease the pressure, but we don't cure glaucoma. This is something that for the patient need to be very clear. We use drops, we can use laser surgery, but we don't cure glaucoma. The patient need to be seen for life because sometimes even with the treatment, the pressure is still not good to stop the glaucoma.
And it's also very important to keep in perspective.
Glaucoma is a lifelong condition, but it's very manageable. With the treatment that we have today, most people keep the good vision for the rest of their lives. Sometimes people get discouraged when they hear the word glaucoma, but the technology is advancing very fast, very fast.
So if you're facing glaucoma today or in your future, remember,
glaucoma doesn't have to mean blindness. With early detection, modern treatments, and communication between doctors and patients, together we can protect your sight for life.
now with a better understanding of what glaucoma is, let's discover what's in development for emerging treatments of this eye disease. For this, we've enlisted the help of our second expert. Dr. Sahar Bedrood is a board-certified expert in complex and advanced glaucoma surgery and interventional treatment utilizing both cutting-edge surgical and non-surgical methods. In addition to years of instructing in academic medicine, Dr. Bedrood is now in private clinical practice based in Los Angeles. Dr. Bedrood first tells us, although a common disease, the severity of a patient's glaucoma is truly on a spectrum, ranging from
mild glaucoma, which is a large majority of our glaucoma patients. In a mild case, patients may not notice anything, which is great. We want to keep it in that mild stage.
But at the other end of the glaucoma spectrum,
unfortunately, if it progresses to more moderate or advanced, what that means is they start to lose their peripheral vision. It can actually be so much loss that it tunnels in and you can start to lose central vision, which would be noticeable vision.
Which, in turn, means the level of impact varies widely as well.
Some patients will notice that they misstep because their peripheral vision or the vision down below where the steps are, they don't see them as well. Some patients will complain of a fogginess in their vision. And then as it advances, unfortunately, it becomes more dim. And this is one of the more devastating processes in glaucoma. It can lead to complete vision loss.
Fortunately,
that is not as common. Large majority of our patients, we keep them in the mild stage, hopefully. But depending on the patient's genetics, depending on how their care has been, depending on if we can control their pressures, they can advance, and then that can lead to some devastating vision loss.
Dr. Bedrood tells us, historically, diagnostics and treatments for glaucoma have changed over the past few decades.
30, 20, even 15 years ago, the way glaucoma was seen and treated diagnostically and treatment-wise was more simple. You would diagnose a patient with glaucoma based on their nerve appearance, based on their eye pressure, based on their vision loss. And those things combined, you would then start them on some eye drops. If the eye drops don't work, you can escalate to some kind of surgery.
In other words, the approach was rather regimented.
In more traditional thinking, it was very stepwise. You start the drops, you add the drops, you wait for vision loss, and then you do surgery.
But that's all changing, because in more recent years,
what has really shifted in the mindset of glaucoma specialists lately because of technologies that have come on board is you diagnose earlier, you treat earlier, and you don't necessarily need to use 2-3 different eye drops. You can do laser, you can do minimally invasive surgery. You treat and intervene a little bit earlier in the process, and by doing so, the thought is you reduce the chance of meaningful vision loss.
Making these more recent advancements in diagnostics, treatments, and therapies for glaucoma a real renaissance.
Treatment for glaucoma has changed in that there is a huge amount of increase in medical devices or surgical devices that offer more minimally invasive surgery. Traditionally, they did these bigger surgeries. And while those surgeries are still done, you don't want to do those big surgeries if a patient is earlier stage of glaucoma because they're a little bit riskier. So you kind of reserve them for more advanced cases.
She adds, what prompted these advancements in glaucoma treatment modalities
was the medical devices that came out that allowed smaller, less invasive surgeries to help lower the eye pressure in patients. And so between the medical devices that are coming out and the diagnostics that are coming out where we can try to identify glaucoma patients earlier and identify the nerve layers that are being lost earlier in the disease process than we did 30 years ago.
And this more proactive approach allows earlier treatment, which is vital because, again,
glaucoma is a very chronic disease. It is something that happens slowly and over time. So by lowering the eye pressure with a less invasive surgery or laser early in the disease process, we may be able to slow down the trajectory of vision loss.
One such advancement are smart contact lenses, an exciting technology in development that Dr. Bedrud is here to give expert insights on today. She says smart contact lenses are
a soft contact lens that looks like any other contact lens. It's placed in the eye either by the physician or by the patient themselves. And the smart contact lens has a mechanism that measures the pressure of the eye while it's in there.
Which is groundbreaking.
Because the only time we know the true pressure of the patient's eye is when they come to the clinic. And that may be every 3 months, every 6 months, or even once a year. And that simply is not enough to understand how the eye is behaving and how the pressure is when we're not monitoring it.
Dr. Bedrud gives a specific example of when and how this might be critical.
A lot of our patients, their pressure will go up at nighttime, and we want to monitor that. What if the patient's pressure is spiking very high during the evening? Well, then we know we need to treat more aggressively during that time. The smart contact lens allows us a non-invasive, fairly straightforward way to monitor the pressure remotely outside of the clinic.
Now, before we learn more about smart contact lenses, we need to emphasize that they
has not yet been FDA approved. They're in clinical trials, and hopefully in the next coming years, they will be approved for patients to use.
So while they're on the horizon, smart contact lenses are not on the market. Not yet, anyway. Still, we asked Dr. Bedrud, once approved, will patients wear smart contact lenses only sometimes or all the time?
The one that's coming out into the market, it's really used for diagnostic purposes. So the patient puts it in for about 24 hours, then takes it out. But during that time, it's associated with an app or a device that can measure the pressure, and then that device then reports it to the physician, so the doctor knows how high the pressure was every 2 hours, for example.
These initial smart contact lenses are
meant to come out. Now, I'm sure as technology evolves, they can put a prescription in there so the patient can see. They can potentially have it in there all the time if it's a comfortable contact lens for the patient. But I don't think in the initial phases it's going to be something that patients will have every day. Not yet, anyways.
Making initial smart contact lenses a monitoring device, similar to other wearable devices like an Apple Watch or an Oura Ring.
Exactly, yes, except it now can go on top of your eye, and through physics and fluidics, it can figure out how high the pressure of the eye is.
How does the smart contact lens measure eye pressure? She gives us the basics of the functionality.
There are a number that are in study. The one that I'm aware of is called MyLens, and that's in pretty advanced clinical trials. That particular one, there's a fluid within the contact lens, and it reacts to the pressure changes. And when it does that, it moves around on the contact lens on a little measurement gradient. And then what you do is take your phone, and there's an app. You open your eye, you take a picture, and depending on where the fluid is on the mark of that lens, correlates to the pressure of the eye.
Pretty cool, huh? Dr. Bedrud thinks so.
It's a very interesting, non-electronic way to monitor the pressure of the eye, but yet still be able to relay it to an app and then give that data to the doctor.
As mentioned, there are multiple smart contact lenses in development, some aiming to dispense medications.
What it would basically do is, instead of having the patient have to put drops in morning and night, they can use a contact lens and potentially it can secrete the glaucoma drop all day. So you have more control throughout the day and the patients don't have to necessarily put a drop in their eye.
But although great in theory, there have been some challenges in application.
They have some challenges to overcome to make that something that patients can place in realistically and want to place in realistically. Some patients probably prefer just to put a drop in once in the morning, but how wonderful would it be if you're using your own contact lens prescription, but you have a way to also control your pressure the entire time and potentially monitor your pressure the entire time.
Where and how will data collected from smart contact lenses be stored and analyzed?
The the ones that are closer to being on the market don't have an electronic interface. They are using physics and fluidics and how the fluid moves around on the eye to figure out what the pressure is.
Then how will data be transferred in the initial smart lenses?
These all have to be connected to a phone or an app with a camera and a special lens on there. You open your eye, take a picture with a special camera lens that's attached to your phone, and then that picture gets imported into this app, and then that can be sent to the doctor to try to analyze what kind of behavior their eye pressure had over the 24 hours that they were monitoring.
Once FDA approved, could smart contact lenses be used by anyone with glaucoma, or are they not suitable for some patients?
There are patients who may not do well with a contact lens. A lot of our older patients with hand mobility issues, those patients are going to have a tough time taking a contact lens and putting it in their eye.
Although there might be a workaround for some, in which case
the doctor can do that. So the patient comes in, we place the contact lens on their eye, they go home with it, they come back the next day, doctor removes the lens and also then gathers all of the data. So there does have to be some cooperation and ability to do this, and not every patient are going to be amenable to this type of technology.
Smart contact lenses will continue to evolve, including ones that could secrete glaucoma medications. Why is this important?
One of the things that we've noticed over time is compliance of eye drops for patients is difficult. Patients don't typically like the feeling that goes in with some of the drops. It burns. Patients forget to put the drops in. So all of these lead to non-adherence or non-compliance.
And unfortunately, can lead to
progression of glaucoma. So a contact lens is a way to deliver the medication without the patient needing to be as active in it. Ideally, it would be a contact lens you can just leave in maybe for a week. I'm not suggesting there's anything out there that has that, but that's the way I would see it being useful for a patient.
Technologies for enhancing glaucoma management won't end with smart contact lenses.
Absolutely. There are so many devices and medication-based innovations. For example, there are ways to place the medication in the eye with a tiny little implant that's microscopic, has all the medication you need for 2 to 3 years. So the patient doesn't need to take any topical drops, doesn't need to do anything, just needs to come to their visits. So that, I think, is the wave of the future for glaucoma management.
That should be encouraging news, because on the horizon,
there is a way for us to monitor and potentially help patients treat their glaucoma when they're not with the doctor. If we get information from a smart contact lens, we can start treating that patient earlier and prevent any future vision loss.
And that should create
a sense of hope for the patients, because we will have less and less patients suffering from the devastating vision loss that glaucoma can cause. So I really, truly believe that there is a lot of positivity and hope in our field.
We'll end on that positive note for this edition of CTSI Discovery Radio. As always, thanks to each of our guests for appearing on today's show. Dr. Sylvia Lara Moses and Dr. Sahar Bedrood. I hope you've discovered something by listening to today's show. And I'm doubly hopeful you'll join us again next time. CTSI Discovery Radio airs the third Friday of every month. Make an appointment on your calendar and join us for each episode. On behalf of the Clinical and Translational Science Institute of Southeast Wisconsin and all of our affiliate partners and members, I'm Brian Belmer, wishing you happier, healthier days ahead. For more information about research or to listen to the podcast of this or any of our shows on demand, please visit our website at ctsi.mcw.edu. CTSI Discovery Radio is written, produced, and hosted by Brian Belmer in collaboration with WMSE Radio. The CTSI and this program are under the interim direction of Dr. Julie Freed.